Hello, everyone. Welcome to one of our FMEC 2022 annual meeting seminar samplers, Humanizing the Healthcare System and Dissecting the Complex, Family Physicians as Leaders. Just wanted to tell you a little bit about the FMEC. Our goal is to really promote family medicine and primary care to medical students as we support residents as they transition into their careers. Ultimately, we would like to strengthen academic family medicine. And so in order for us to do that, we create and sustain quality improvement initiatives, and as well as stimulate innovative approaches to primary care service delivery. That is something that you are going to see today with our topic. We would like to welcome you to join us in October for our annual meeting. It will be held October 13th through 15th at the Rhode Island Convention Center in Providence, Rhode Island. It is an opportunity for you to come and learn, to meet new people, and to understand residency education and faculty development at a greater level. So I'm really excited for today's speakers. These are my colleagues that I work with on the FMEC board, Dr. Raj Wooliver, Dr. Aaron George, and Dr. Amy Crawford Fauché. All will be speaking to us today about leadership. So thank you for joining us, and I welcome our speakers to begin.
Good afternoon, and thank you all so much for joining us today. Aaron and Amy and I are very excited to talk with you a little bit about leadership. Healthcare has to be one of the most complex environments to think about how you show up as a leader. But we also think that family physicians have a unique set of skills that allow us to perform at a higher level and to think more broadly as to how we show up as leaders. And we look forward to talking a little bit in more detail about that over the course of our presentation. My name is Raj Wooliver. I am recently transitioned into a new program director role at a program in Portsmouth, New Hampshire. I have been the program director at 2 other residencies, both in Maine, and also served as the chief of the medical staff at Central Maine Medical Center, where I oversaw a medical staff of around 400 providers, including physicians, PAs, and NPs. I still harken back to my days as a chief resident and think of that role as probably one of the more challenging leadership roles I've taken on, because you show up as a sort of a peer leader. And often you'll find yourselves either as the person who raises their hand or the person who gets left standing in front when everyone else steps back. And you are thrust into leadership positions, and we hope that some of the lessons we talk about today will allow you to think about how you show up as a leader in a new way. Aaron, I'm going to turn it over to you.
Hi, I'm Aaron George. I'm also a board member for FMEC, and I am the Associate Dean for Clinical Education for the proposed Emeritus School of Osteopathic Medicine, a new medical school that we're building that we're planning to open in 2025 in rural Western Maryland. I also have just finished a role as the Chief Medical Officer for our health system, and prior to that, helped to build a family medicine residency here as well. And as I reflect upon the roles, the characteristics of a family physician, and I think about moving between those different jobs and those different leadership positions, I can't think of a training that's better to prepare for the adaptability of multiple roles of leadership, the changes that occur day to day, than that of a family medicine training. So I'm excited to share some of my experiences and talk a little bit about how your training also prepares you to be an excellent leader in healthcare.
And Amy, welcome.
Hey, folks. Classic, right? That add-on patient was the death of me. Hi, everybody. Thanks for joining us. I'm Amy Crawford Fauché. I currently serve as the vice chair for both the departments of family medicine and our primary care institute at Allegheny Health Network in Pittsburgh. That constitutes about 200 doctors, 1,500 employees, and 75 offices. So I'm using a lot of my previous life as a program director and faculty meeting about when we were recruiting residents and working on the flow of a residency practice And now it's kind of writ large into a much larger system where I'm now hiring grown-up docs and working on operations as an institute level. So as I'm sure you two have already said, it has been an amazing journey through my work with the FMEC, but also as we move along in life about how we get trained or how our antenna get up to what leadership actually means. And when the rest of the world and medicine isn't saying, oh my gosh, you family docs, you have it going down, you know how to do this. To kind of using the skills we have as family docs. So I'm looking forward to this conversation this afternoon as we share some of our, I don't know, maybe it's not wisdom, but at least experience.
Great. Thanks, Amy. We have nothing to disclose. I'm going to launch this right in. I just want to review some of the objectives that we hope to accomplish this afternoon. First, we just want to give you some time to think about leadership characteristics and traits. We have all been led. Sadly, probably we have, at least our recollection is that we've experienced probably more not so great leaders than we have really great leaders. But there are some universal characteristics, and I'd like you to take a little bit of time to think about what comes to mind for you when you think of a great leader. Is it someone who is motivational and inspirational and is an orator and stands at the front, or is it someone that really does the work side by side with you and leads from within? Taking that one step further, we're going to try and help to describe some of the common characteristics of family physicians, some of the unique aspects of our training as family doctors, and how they help to prepare us to be leaders in the complex environment of American healthcare. And then finally, we want to spend some time talking about how we can better prepare future family physicians to be the leaders that we need as we move forward from here. I would contend that there are very few born leaders. Like most things in life, becoming a good leader requires a fair bit of work. It's not just an inherent skill. And residency is the perfect environment to start thinking about how you can show up as a future leader, and residencies should probably do a better job of helping to create curricula and other experiences that prepare future leaders. Over to you, Amy.
All righty, next slide. So, as I think we alluded to in our introductions, what is it that makes someone a good leader? And I think, as Roz said, you may have an image, but when you really think about who gets things done, and we talk about leadership as helping to inspire others so that you're all working together to get things done, what is it about us that makes us good at this? And I think we'll talk about that quite a bit. What is the next slide?
Aaron's going to talk about the current situation, and then we'll move on to characteristics.
Okay, got it. So I think in broad strokes, family docs are naturally suited for leadership because we're naturally suited to what we do every day, whether we're seeing patients or teaching or other things, which is we look broad-based. We have to look, we are not zoning in on one particular problem / organ system / issue going on. We look broadly. We look at the person, the family, the community, and those skills can come out of the clinic, of the office room, exam room, in terms of how we interact with others. So we have that as well. We lead diverse teams anyway, as you can imagine, in the hospital, on L&D, in the nursing home, in the office. That's a skill set of, reading people, knowing them where they are, and being able to look at things very practically. And again, not detached. I think we're very involved, but be able to really see multiple sides of every issue, because we do that as we're dealing with clinical uncertainty every day. They're the same skills that are translated out into the wider world of healthcare leadership.
Awesome.
I'd like you to take a quick moment, and if you will, close your eyes or just think for a second about what a family physician looks like. So just think about a family doctor. Maybe you have an image in your mind about a clinic or a hospital or a community, but odds are, and when you ask this question to most people, they would think of a solo physician in a white coat in a community office. And that is our traditional perspective. We are in every community, we're in every hospital, we're across the board caring for patients and for families. But the reality when you think about family medicine is that we are pervasive across the entire spectrum of healthcare delivery. There are over 120,000 active practicing family physicians. When you break it down, that's over 13% of the entire physician workforce. So just think about that for a second. That's not 13% that are all practicing one by one in communities across the country. That model of Marcus Welby medicine, it still exists in some places. But the reality is because family physicians are trained to see patients regardless of age, disease state, or demographic, we're everywhere. And we need to start thinking in that framework that across that entire spectrum of patient care, care delivery, systems and organizations, family physicians are prevalent because we really are chameleons. And think about your training and the training of your colleagues. When you finish your residency, you take the things you like and you settle in the community and you adapt to the needs of that community. And that's one of the unique characteristics of family physicians, that we bring that ability to adapt to the needs around us. And we like this term as we've prepared this presentation, that family physicians are chameleons, that we can change and adapt with the growth that exists around us. So when you think every other specialty starts like this in medical school and narrows through their training, and family physicians are truly among the only physicians that start like this and broaden. And that gives us the chance to be in health centers, to be medical directors at federally qualified facilities, in hospitals and C-suites across the country, public health. And so when you think of the paradigm for family medicine, if you thought about that solo family physician, that still exists. But we want you to also think about that full spectrum, that family doctors are everywhere. We maintain nationally a compendium of family physicians that are CEOs, CMOs, and deans of medical schools. And we really are pervasive across the healthcare system. So with that, I'll pass it on to Raj. I told you where we are. He can tell you who we are.
So we've already been helping you to start thinking about some of these things, but let's just dive a little bit deeper into some of the characteristics of family physicians. And a lot of these things listed on this slide are just sort of an inherent part of our training and our experience. And I think a lot of it is rooted in the fact, as Aaron pointed out, that we are primarily a clinical specialty. And so often our approach to leadership is one that we learn in the course of taking care of our patients in the exam room in our clinics and in the hospital rooms and on the labor and delivery floor. We are naturals at seeing the big picture. One of the things that we do as clinical family physicians is that we take the inputs of the cardiologist and the nephrologist, the physical therapist, the other providers that are engaged in the care of our patients, and we help to turn them into something that's understandable and actionable. And those are the very same kinds of big picture skills that are required of leadership. As leaders, we're able to keep the patient at the center, but also consider the importance of finance and human resources and patient experience and access, and pull all of those into a coherent big picture. One of the other things that I really like to talk about is our comfort with uncertainty and ambiguity. It's an inherent part of what we do every single day as family physicians. If you're a cardiologist, you can be more or less sure that most of the patients coming through your door on any given day are coming through the door because there's something going on with their heart. As a family doctor, most of the time we have no earthly idea exactly why our patients are coming through the door to see us. And half the time our patients don't really know exactly why they're coming through the door to see us, except that it's time to come see their doctor. And talk about all of that undifferentiated kind of stuff that's really hard to look up in a textbook or even find on up to date because it's the vagaries of human life. And so that's the world we live in. We live in the gray zone. We work in uncertainties and ambiguities all the time, and we have learned a certain degree of comfort that that's just sort of the real world, that things are not black and white very often. That there are not only yeses and nos, but a whole range of different approaches and ideas. And that willingness and that comfort of being in the gray zone is the reality of being a leader. We're leading people, we're not leading widgets. And so we think in the same way about how to take a variety of inputs. And none of us has the crystal ball to know exactly where we are headed. So it's that same kind of uncertainty and ambiguity that are inherent in the way that we practice as family doctors. The balance and breadth of our experiences are also incredibly important. We have an understanding of all of the areas of medicine because that's where we train. As Aaron highlighted, we're the only specialty that we actually get broader as we make our way through training. We have a comfort in the emergency room. We have a comfort on labor and delivery. We're comfortable in the ICU, the hospital ward, the outpatient clinic. So having a true understanding and appreciation for the challenges of each of those different environments helps us to be that leader with a sense of the bigger picture. Often those areas, while they ideally work in cohort and in balance with each other, are often competing for limited resources and have different objectives to get through their days. And so our ability to understand and appreciate that big picture can help us to work in the area of collaboration and not competition. We're adept at change. I think the fact that our training is so broad, that we are often the new kid on the block as we make our way through residencies, allows us to be pretty adept at change. And we have a willingness to accept new environments and make the most of learning what we have to learn each time we come to a new location or a new task. Multitasking is an inherent part of what we do every single day. Amy just found herself in the midst of some multitasking as she was trying to wrap up some unexpected patients added to her schedule. It's just the world that we live in. And with all of those things considered, we just have, as family physicians, we have a natural command of the complex. It's that big picture, taking all of the pieces into a coherent whole. Now, there are plenty of gifted cardiology leaders and nephrology leaders, but I also think there are some differences in the way that a cardiologist or an orthopedic surgeon thinks about the world and how they show up as a leader. As Aaron highlighted, we are the largest clinical specialty. That clinical understanding and appreciation is about keeping the patient at the center. I think in healthcare, leaders that remember that the work that we do every day is about taking great care of our patients are the ones that remember the why of it. They're the ones that inspire us and motivate us and remind us of the important work and honestly the privilege that it is to be a part of healthcare. So keeping the patient at the center is a part of our mission and vision, and that's will see us through every day as a leader. I think family physicians have a great appreciation for the importance of that patient-physician relationship. And that's one of the things that drives us. Compared to other clinical leaders, as highlighted already, we have wider experience. Our training is broader. We work in all the different environments. We interact with specialties across the spectrum. Our experience is broad. So it gives us a greater understanding and appreciation for all of the competing demands of the healthcare environment. As I've already mentioned, we're comfortable in a whole variety of clinical areas. And with a variety of patient populations. We take care of kids, we take care of pregnant ladies, we take care of older folks and families. There is no patient population that's not a part of a family medicine practice. That allows us to have a broader perspective than the cardiologist or the nephrologist most of the time. And then one of the core values of family medicine is our willingness to invest longitudinally. It's about knowing our patients over time. Leadership is not a sprint, it's a marathon kind of event. It's longitudinal. We tend to think about making change and we put pressure on ourselves to do it quickly. But if you look at the models of how change is actually made, it's more in years, it's not in months. And it's more in 4 or 5 or 6 or 10 years that true change really is accomplished. That's sort of hard to wrap your head around because we get wrapped up in thinking about things in month intervals or a couple of year intervals. So to think that you are investing as a leader in a longitudinal experience of true change, that is in the 5 to 10 year range. But we are about longitudinal, long-term relationships. That's what family physicians are here to do. And then lastly, the sort of circling back to our adaptability, flexibility, willingness to think about different approaches, to embrace different styles of leadership, depending on the situation that we find ourselves in, sort of that chameleon-like approach to how we show up. One of the hallmarks of being a family doctor. So on that, I am gonna turn it over to, and I moved my page, so I'm not entirely sure who it goes to next. But either Aaron or Amy is coming up next to talk a bit about some of the potential pitfalls.
I will talk about those pitfalls, Raj. Thank you. So you may have all heard these things when you're a medical student and being encouraged or discouraged to go into whatever specialty. You might have to have these deep thoughts about yourself as well. So here are some of the ones that are potential pitfalls, not for our leadership, but for folks, other people's, or maybe your own perception of yourself as a leader. So you may have heard all these. So I think for one, for sure, it's that we're just too nice. Which really, when you think about it, is really ridiculous, because we are nice people generally. And honestly, patients and other coworkers really tend to appreciate and value that. I think that being too nice is not the same as not being able to tackle tough or unpopular decisions. And we do this all the time. Again, in the patient room, I care very deeply about how you're doing, and I'm very worried about your alcohol use. How can we work together to work on that? No, I'm not going to write a letter to get you out of jury duty. And no, I'm not going to refill that particular medication until we try some other things first. So we do this all the time. Being nice and being able to make critical decisions are not mutually exclusive. So I think that's a key one. The jack of all trades, we've all heard that master of none. And that's one of those things. And if you think back to the way medicine developed historically, we all medicine started as all general practitioners. And then as we developed more knowledge and skills, that was where the subspecialization really evolved. I would posit that most people become specialists, not because of some of the stuff we all talk about, but mainly because as doctors, we really like getting things right. We really like to be right. We really don't like that uncertainty feeling, which of course, as Raj has already said, we live in that uncertainty feeling. We live in the gray zone. So that doesn't scare us as much. I think a lot of doctors subspecialize because it's much more comfortable for them to know a lot about one thing or a few things than to know a fairly moderate amount about a lot of things. So you may have heard this, but the jack of all trades, master of none, that's only a piece. And it's a misquote of a longer quote that actually was a compliment. So the full quote is, jack of all trades is a master of none, but oftentimes better than a master of one. So I think that we have to own that whenever someone comes to us going, well, what do you know? And you're like, well, actually, this is what I know. And this is why it's so valuable. And the third point is that we're too altruistic and not based in reality. That's kind of a tangent on the we're too nice. But there's the other piece of that we are not, ready to get down and dirty into the financial realities of healthcare. I would take a step back from that and say, let's think about what a focus of both medical care and public health has been recently, which is really actually valuing and measuring and acting on the social determinants of health. Yeah, that was seen as really an altruistic thing that wasn't really medicine for a very long time. You can also suggest that with public health and family medicine, we're the drivers of making that more encompassing within healthcare. We understand fully that high quality preventive care and comprehensive primary care actually does help the bottom line for patients and for healthcare systems. So we get it. Again, these are both ands, they're not either or. We can be altruistic because that's what drew us to this specialty, and also be fully advanced in the reality, much of which is very broken in American healthcare. So again, let's take these pitfalls and turn them into the strengths that they actually can be. And part of that comes down to having confidence in your own belief, your own skills, whether or not other people are kind of at validating that for you. And that's part of, I think, why we're here, is to help validate you in your journey. Yeah, I think those are the main ones.
So it's a perfect handoff on validation and self-validation. On the next slide, we wanted to offer some tangible and practical advice that anyone across the training spectrum, from a resident, young physician to a senior physician, could take from this session and try to think about in their unique local context. And so we touched on a number of the characteristics of family physicians in terms of their training and how they approach patient care. And if you just imagine a subtle head shift, a subtle shift, what when you apply those characteristics occurs when you apply it to health systems, to organizations, to communities, to businesses and others. So think about those same dynamics. I'm centered on patients first. When you apply that to any organization in healthcare, from Google to Walgreens to your local urgent care, that resonates because it's really the why of what we do. Boards are going to care about that, leadership's going to care about that, and consumers are going to care about it. So being patient-centric matters. Nobody wants to have a physician leader who signed up because of the paycheck. They want someone who signed up because they care about patients. So hold on to that. That's important. The family and community-minded plays into the bigger picture. So we have that global perspective. We understand care coordination. We understand multiple team members, high levels of communication, and high levels of uncertainty. So as you're approaching the potential for your role in leadership, think about selling that dynamic of yourself, that you have the capacity as a leader to manage all of those things, to stand at the bigger picture, that you don't need to have that micromanaged, microscopic view, but rather you can understand the whole context and then the layers that match up between an organization or a system's community, their families, their patients, and then what it means at the individual one-on-one level and up and down. Because leaders are able to visualize that global 10,000-foot view down to the ground floor. And so you should sell that. And again, regardless of your potential as a leader, whether it's being a medical director, leading a medical team, stepping into a quality role, or increasingly what we're seeing in family physicians, stepping into venture capital and pilot programs as family physicians are being recruited and targeted to help lead some disruptors in the healthcare industry. And you better believe there's a lot of your colleagues that are selling the things that we're talking. They're conveying their leadership because they understand navigation across the healthcare system. They understand the investment in healing relationships and keeping patients at the center. We shouldn't lose sight of these. I think one of the things that happens is it becomes so commonplace in the rhetoric that we employ as family physicians that we don't often realize how different of a philosophy this is from some of the other disciplines in medicine. So it's important to convey these as Amy had offered, that we need to sell ourselves sometimes. And these are leadership capabilities that each of you have that you just may not realize are important to highlight. So on the next slide, we do want to be mindful of how we get here. How do we change the training paradigm? How do we influence upstream in high school and college towards primary care leaders? How do we influence medical school training that helps to promote a foundation for ultimately a residency that fosters leadership? And so we have a couple of tangible, specific takebacks for anyone that's on the call today that would like to invest specifically in a residency training or a local training enterprise, things that you can take back right now. And one of the pitfalls, I'll come back to the term pitfalls, that our traditional models have employed is the assumption that leadership can be boxed up and packaged and delivered in a small package, right? So you have a leadership elective and it's 2 weeks in your residency. So good luck, you better learn everything it takes to be a leader in those 2 weeks. Or we have a 1-hour didactic session, or we give them a textbook. And you say, here's a book on leadership. Why don't you read it? And then you've learned a little bit. And those simply don't work because leadership needs to be longitudinal, it needs to be experiential, and it needs to be mentored. So think about those three things. Anytime you have a consideration for an opportunity to develop leaders in your own organization, in your residency, in your teams, are these longitudinal? In other words, is there repetition and opportunities to engage in it over time? Is it experiential? In other words, it has to be acted. So leadership is not something to just sit back and talk about and hope it happens. And then the last one is it mentored? Do you have the ability to take a future leader, and this may be you, or could be a colleague that you're hoping to develop, prep for what a leadership experience could look like, go through the activity itself, and then debrief what happened. And we have a tremendous opportunity to deploy just this sort of leadership training within our residencies. And this is the chief resident role. Now, unfortunately, most chief resident roles are effectively chief schedulers and chief whining officers, because they're the ones that buffer the rest of the program faculty from the whining from residents. Let's be honest, that a lot of programs utilize them in that role. And then they schedule. And in a way, that's an opportunity to engage in crucial conversations, to do administrative complexity. But I would challenge any educators on the workshop today to consider ways to make the chief resident role a truly experiential one that's set up with expectations that there's early education, and that after experiential and facilitated activities of leadership occur, driving a team through change, working through updates, that then ultimately you or another faculty member are able to debrief what happened, not structurally from the outcomes, but debrief the leadership itself. And that takes another step, another level. But we believe this is the sort of tangible leadership training that we need to do to move beyond the 1-hour CME, like the one you're in right now, the textbook, or the 2-week elective. So we hope you'll consider these as specific takeaways from our session that we believe can embed these in our trainings for the future.
Awesome. Thanks, Aaron. And I'm going to turn it over to Amy to wrap it up for us, to share some big picture ideas, and then we'll have some time for questions after that.
That's good. So again, as we've, I think, articulated many different ways, health systems have elevated family docs into leadership roles. We saw that definitely during the pandemic. That's how I got to where I am. I put my hand up and said, what are we doing in primary care about COVID? And then found myself at the table. Don't lose those opportunities. Sometimes it doesn't look clear, like it's going to be a leadership conduit. Sometimes it's just having those antenna out to go, if something looks interesting, I'm going to give it a try. If a door opens and someone waves you in, that's terrific. That it doesn't usually happen that way. The door might crack open and you can take that step through and folks will go, oh, good, you're here. Sometimes the door doesn't open, but if you can crack a window open and crawl through, that works too. So I think part of this is no matter where you are in your career, and this is medical school through, senior clinical physician, is look around you, look outside your box, look outside what you've been usually doing, and get involved, even a small thing. So there are lots of opportunities in addition to what Raj talked about within the residency training. And one thing about residency training, one thing we do at our program is that we actually have each of our residents serve on either a network-wide or hospital committee. And so you may not be leading that committee, but that gets you working in an interdisciplinary team, you get known, and some of them do have very visible, vocal, and important roles on those committees. So that's kind of a neat thing to add. But if you look at the national level, most of our two big organizations, the AAFP and STFM, both have leadership training available to folks at various stages along the way. So explore that, take advantage of it. There are also other physician executive organizations. The American Association of Physician Leaders, AAPL, is a big one. And that's really a nice thing to explore because you can take courses either online or in person in the whole spectrum of things. Most of the business schools actually, or many of them, will give certificate or executive education coursework in this kind of management leadership kind of thing. So it really depends on how your interests evolve, your resources, both in time and finances, and maybe what your organization will support. So it's really nice. We have informal ways to lead at the training level, in the community level. And then if you're interested in doing more of this, you have both our physician organizations and others that can help formalize it for you. So I think, Aaron, you're going to bring it home.
So in summary, we know that this is this takes intention. The fact that you've signed on, the fact that you have interest, I think is a good place to start. It's important to share ultimately the sentiment, the mentality, because we do want to raise awareness about the importance that, as we believe, family physicians are the solution to healthcare leadership gaps. Then we need to intentionally train towards that gap. So it's not only stepping into them, but it's being prepared to step into them effectively. We do believe we are the solution, and we welcome you to be a part of it as well. We entertain any questions or discussion from the group. We certainly have time to have some conversation about this. So with that, we thank you so much for joining, and we look forward to connecting with you now and again in the future.
Well, I'd like to extend a thank you to the 3 panelists, my amazing colleagues. We appreciate this talk a lot. If you do have questions and you don't want to ask them, you can out loud, you can always put them in the chat and I'd be happy to read. I have a question for you all just to start out with. You outlined some next steps and really highlighted why leadership is important and some of the things that we can do. Can each of you give just one tangible thing that residency leadership can implement in their program to help develop leaders?
It's one thing I would highlight, and I think looking at the slide that Aaron covered about what already happens in residency, and leadership training should be experiential. And we did sort of highlight that word, but it's not, just about signing up for the committee and sort of sitting in the background. It's really about experiential stuff. And I guess one area that I would like us to do better at, and that I think really helps to build leadership, is a focus on quality improvement activities. And that can be in the hospital or in our clinics, but we have a little more latitude in our clinics usually. But having residents actually experience leadership, organizing, running, gathering information around quality improvement not only keeps the patient at the focus, which is the thing that motivates all of us, it also helps you to think about how to organize your approach to a project and then motivate those around you to participate in gathering some important information to allow us to work more effectively, to take better care of our patients. I think most programs do some of that, but we could probably do better at that and highlight it as not just a QI activity, but also a leadership building activity.
I think a piece of it too, Tracy, is to also recognize, as we said, the skills that folks already are using every day are leadership skills. And I think an intern doesn't see themselves as leading when they are helping to teach a medical student something. When a more senior resident is running a code and you are now managing 15 people who showed up in the room, or you're de-escalating either a patient situation or, again, those 15 people who showed up in the room, so part of the debrief we have as teachers, I think, is to go, look what you showed there. This is the skill. Because again, we don't see it that way. We're fairly humble, as a specialty. We just think that's a Tuesday. That's what we do, when recognizing that these are skills that are so translatable.
I think the other thing that I would offer is something that's incredibly easy to start doing tomorrow is to not paint leadership into a box. In other words, we have for far too long assumed that the leader is the person that's running the board meeting, that raises their hand and is extroverted. And unfortunately, family physicians are often cited as being the ones that don't want to sit at the table and don't want to run forward. And so I would encourage that some of the best leaders that I know are the quietest people in the room, and they're the ones that aren't running the board meetings. So leadership is not necessarily about being the one at the front of the podium of the microphone and having the extroverted characteristics to lead. Sometimes leadership is the person that has the insight to understand global impact and perspective, to champion initiatives and see pathways that others don't. And so I could say right now for any residency program, it would be acknowledging that leaders happen at all points of our healthcare delivery. During hospital transitions and sign out, leadership occurs. During a code, as Amy mentioned, leadership occurs. And the leader isn't necessarily the person running the code. Sometimes leadership is the individual that's accountable to follow the directions and make sure things happen. So leadership occurs longitudinally in many different ways without being the person that's talking the loudest.
Thank you all. We don't have any other questions in the chat, so I will take the opportunity to ask you one more. And this is actually for all 3 of you. There's so much in the media about burnout, and we've read, about physician burnout, and especially in family medicine with the pandemic, and some of the things that occur with that are this lack of control. Can you each talk about how leadership can help with personal and physician fulfillment with our careers?
I do have a favorite quote that I bring up a lot, but and it's wellness should be about finding freedom in our work, not freedom from our work. And to me, and I certainly have some insight that not everyone will share this exact same feeling, but to me, the work we get to do as a family doctor has so much inherent fulfillment and gratification that if we can stay focused on the difference that we get to make in the lives of our patients, and as a leader in those that are working with us and around us, that's where the freedom and the wellness should be. And I think we have to do a better job of getting rid of those death by 1,000 paper cut annoyances that interfere with our ability to appreciate those interactions and stay focused on that. Wellness is never going to be about a coupon for a massage or fancier soda waters in the resident room. Those things are nice and they make you feel better for the hour massage and the 5 minutes that you get to drink the fancier soda water, but they are not the solution to our issues with burnout and challenges with wellness. It's about reminding ourselves that there is freedom in our work. The work we get to do is incredibly powerful, gratifying. It's a privilege to be someone's family physician or to be the leader of an organization that is focused on taking great care of patients.
I think I'd offer that one of the antidotes to burnout is change agency. So when you see problems, either putting your head in the sand and struggling through them or responding and trying to fix them. And I think one component of leadership is actually the change agency to respond to problems when you find them. And I think the next layer then too is that as leaders prove themselves in any organization, system, group, there's a likelihood that they'll be invited to have protected time to use that and extend that. So in other words, as a family physician that's burnt out, that just puts their head under the pillow and just keeps dealing with it and gets frustrated, versus the family physician that attempts to try to work through and change and champion positive solutions, and over time is invited to maybe be a medical director, a director of quality improvement, maybe a community liaison or something along those lines to help navigate problem solution, which then creates some protected and buffered time for that change agency. So I think that one antidote to wellness is to try to find joy in the things that you do and to carve out the time to do it well.
And I think also to corollary is just to remember what your why is, and people's whys may be a little bit different, and act on those. You know, again, for me, it is wellness is fixing the system as much as it is fixing your response to a broken system. So, you know, that's what I focus on. What I'm trying to do in my current role is how do I make this, how do I help my colleagues get a little more autonomy, a little more control over these things that are the death by 1,000 paper cuts, so that it's easier for us to take good care of patients. So, which doesn't mean it's not hard and not distressing at times too. You know, this is not all sunshine. Change is really hard. Leadership is hard. Seeing patients is hard at times and gratifying and rewarding. It's all of those things, you know. But I think recognizing that if you're not trying in some capacity to change what you don't like, which is, I think, inherently leadership, then there's no hope. There's no hope of things getting better. So, so part of that is just building your leadership journey on the why of what you're doing.
The only other thing I would jump on there, Amy, I appreciated what you're saying is, I guess I would call on all of us to also model the behavior that we want to see. And I was thinking, you know, I'm sure we have all said, oh, the administration has done X, Y, or Z to me again. But I've also been in the room when people say, oh, the administration, when I am the administration. And so it's important to think about.
When your clinical colleagues kind of go, oh yeah, you know, those administrators, I'm like, dude, what do you think I am? I'm both of those things. And that is actually fairly specific to medicine, apparently. You know, if you're the partner in a law firm, you're still a lawyer, and they see both of us. We have created this very strange dichotomy, which is, you know, fairly false, especially when you have physician leaders. That's another reason why it's so important to have physician leaders, because we see both sides. Yeah.
Wow. Thank you all for all those amazing insights. I still do not see any questions in the chat. I will ask Scott if there's anyone with their hand raised.
No, I don't see anyone.
All right. Wonderful. So there is a comment in the chat that I'll read from Dr. Spots. We are uniquely positioned as family doctors to break down that is us versus them mentality. Great job from a great trio. I would have to agree.
Oh, thanks, Doug.
All right. Well, thank you all again so very much for sharing your wisdom and insight and getting us all to think about leadership a little bit more.
Thank you for having us. Appreciate it. Have a good afternoon, everybody.